Well, my formal title is Integrating Outcome Data During Routine Clinical Practice. Is it important? And I guess what I'd like to do is suggest that evidence-based practice is important. And I'll go beyond why do I have to collect data to how I use the data to understand the patient. After listening to Dennis this morning, he's got this analogy in my head all of a sudden, but this is a comparison in a sense, is that risk adjustment is to a statistician as evidence-based practice is to a clinician. So if the statistician is going to understand, I don't know if you understood what he said, but if you're going to understand or appreciate what he said, what do you need? Data. If a clinician is going to understand that evidence-based practice, and I'll use different names for that now. I'm going to say that whole body person or that illness presentation sitting in front of me or a biopsychosocial model sitting in front of me. Well, what do you think you're going to need to understand that? You're going to need data. And you can't treat patients from one construct. You have to think on your feet as a statistician will, and pull in multiple constructs. Another word for that is active ingredients because they change. So you have to think on your feet and look at a whole spectrum of data. Photo starts to give you that data for you to start thinking on your feet. So it's not a why do I have to do it, it's how you should do it to improve your level of competence and understanding of patient care. And when I have a poor outcome on photo, I'm not concerned about it. I want to learn about it. Did I collect enough data to understand what happened? It's easy with successes. It's more challenging to understand why you didn't get an outcome that you thought you should. So is it important? Well, I guess we'll go to the end and say, yes, it is. Okay, so you know the end of the movie. It's going to say yes. But so there were two perspectives here. So from what I just said, we'll consider that more of a professional perspective or from a science-trained clinician's point of view. And the second perspective to answer this question is practical. And I think John Weinberg this morning already kind of got into the practical side, which was a sanitized version of saying what's in it for me or what's in it for my practice. But you know what? Both perspectives are equally important. I don't care which road you follow. If you're a manager and owner, you're going to be practical. If you're a clinician, hopefully if you want to take the next level, you're going to be science-trained or evidence-based. So they're both important. And what's kind of exciting, regardless of which road you follow, it's going to lead to the same endpoint. And this endpoint is being defined for us. And I hope we're going to be defining it too. But the endpoint is defined as value-based purchasing. Pay for performance, or some derivative of reimbursement which is coming our way. And I hope we're not stuck in a Michigan, because I don't want to see that. I hope we can start educating regulators, payers, and consumers on what is needed to be done going forward. So again, both perspectives or both roads are important. And if you start applying both perspectives simultaneously in your practice, you're going to get to that end road quicker. You're going to be ahead of the curve, and you're going to be ready not only to educate, but to handle any changes that are coming. We'll see. Now, just as a short introduction of myself, I am a full-time clinician. That's what I don't get paid to collect outcomes, research. I don't get paid to do administrative work. I do patients, so I guess I'm a trench worker. I see them all day long, all week long. And I work in a suburban hospital-based outpatient clinic. So, of course, my patients are more difficult than yours. Well, based on risk adjustment, we could debate that, and hopefully we should. You should challenge me if I say I get the best outcomes doing this or that. Challenge that person. Challenge any instructor standing in front of a class that you paid $400 for and ask, where's your data? I don't know what you want to tell me, but tell me what data you've collected to support why I'm paying you to talk, whatever. But what I do is I'd like to specialize in neck and back pain patients. I don't always see that. Because when you work in a hospital, if you've got an open space, somebody's stuck in there before you can even do anything about it. So I've protected my turf. I've ghosted the competition on my schedule, and I put research patient or spine patient in the future. So a week down the road, if I know I have 6 spine patients coming in, I make sure I have some slots open. Because if I don't do that, then I see everybody else's patients. So I think it's very important. You want to optimize your outcomes using photo, then you have to invest in that patient, and you have to monitor that patient, and you have to understand that patient each visit. So each visit is an opportunity of growth. And if you lose that, you're going to minimize your function, if you're using photo, and that's what we do. Another learning curve for me was 50% of my patients are older than 65. That's getting to be the norm almost. And they're not nursing home patients. They're community dwelling adults who want to play tennis and who want to do other things and stay active. So it's a good group to work with, but you have to set your limits, and you have to know what construct in which to attack a geriatric person versus a 20-year-old. And the last part of my clinical practice, as a science-trained clinician, I kind of want to start implementing treatments with some evidence of effectiveness. John mentioned that this morning. He uses MDT. I use MDT also, and I also integrate that with the literature. So where does that drive me? Where do I start going? Well, the evidence of effectiveness is driving me towards a biopsychosocial model. Before I get started further, if there are questions, because if I go into warp drive, you just got to slow me down. But if there are questions, please just let me know. So let's practice questions, or raise of hands. How many in here treat lower back pain patients? Okay. Of those hands that are up, how many people are familiar with the literature concerning the management of lower back pain patients? Good. And how many of those hands that are still up classify your patients? Okay, good. All right, so that's exactly what I'm going to be talking about today as far as a science-trained clinician's point of view. So the biopsychosocial model is important. Treatment-based classification systems appear to be promising. If you can integrate that with current clinical practice guidelines, promising. And certainly using outcomes, using data to help drive decisions seems promising to improve and optimize treatment strategies. Well, traditionally, physical therapists measure patient outcomes through informal inquiry. How you doing today, Jack? You feeling better today? You think it's okay with what we're doing? You know, you feeling a little bit better today? What do you want to do today? That type of thing. And we traditionally use impairment measures. Range of motion, goniometer, manual muscle testing, accessory movements, palpation, inspection, what have you. These are all common terms. There's kind of a caution here, because clinical intuition, regardless of the levels or years of experience that you have, informal data and impairment measures do not strongly correlate with the patient's function. Well, that could be a problem, because rehabilitation is function. I remember Dr. DeLito, University of Pittsburgh, uses those two terms synonymously. So if you're quantifying function, you're quantifying rehab. And all you have to do is really start looking at the Guide to Physical Therapy Practice, World Confederation of Physical Therapy. They clearly describe our profession as follows, and that is, I'll just read it, to enhance, restore, maintain, promote optimal physical function, wellness, fitness, and optimal quality of life as it relates to function. I love that last term. In fact, every one of my patients gets a standardized introduction of why you're going to use this photo at intake. And I'll tell you what, I want to understand how that pain, in my case, low back pain, neck pain, etc., is affecting your quality of life and your function. That's why you're here. And I'm very interested in learning more about that. And this is how we're going to set your goals. Okay. So again, there's a clear emphasis on function. That's why the patient hopefully is coming to see you as they control their pain. We need to understand and describe and improve the patient's ability to perform their usual activities, their work activities, and sports and recreation. All of this is important. So selecting psychometrically sound or strong measures of function and physical performance are important. Psychometrically sound is kind of what Dennis had already talked about. We could talk about reliability, validity, responsiveness, etc. Patient self-report surveys do that for you. Clinicians' physical performance scales do that for you. And so both are important. And again, why? To establish treatment goals, equally important is to quantify quality of care that you rendered during treatment. Not only at discharge, but you have to use this information serially. Collect information more frequently using the photo tool during the treatment episode, and you're going to start appreciating how data changes and maybe why functional scores are going down or going up or remaining the same. It gives you some insight as to what's going on in the clinic. So you can't do this with paper and pencil. You can take advantage of it with computer technology. So quantifying measures of function or quantifying measures of rehabilitation. There are two major categories. The clinician's physical performance scales. So if you're working in OCMED or low back pain patients, isn't a lifting test something that you would consider? So maybe you'll do a PILE, a progressive inertial lifting exam. You might do a back performance scale or a simple sock test or whatever. These are considered important to do. And then you have the patient self-report health surveys. That's what photo helps us to do. What's the difference? What type of data does clinicians' physical performance measures give us? This is data concerning what? It provides us with information about the patient's ability to complete a task. Well, self-report measures, just as sound and reliable and valid and responsive, provide us with information concerning the patient's expectations associated with or experiences associated with performing all their tasks. So they complement each other. Okay? And if we are ultimately going to a value-based purchasing or pay-for-performance model or a model driven by us as clinicians to improve reimbursement, then we have to start understanding the integration of both of these features. What you learn in the clinic and what the patient is self-reporting, we both have to understand that and integrate it to really quantify quality of care. So the risk adjustment process, and Dennis and I have talked about this already, needs to be refined. And risk adjustment is a fluid model. So as we collect more data and understand the clinician's input, then perhaps that may become an important risk-adjusted variable. We don't know yet, but there are other variables that we need to collect data on to understand this risk adjustment. So as physical therapists, although we're not statisticians, we need to collect data that we feel is important to us to see if it would fit into a risk-adjusted model, to progress that system also. Why should we have academia telling us what are the most important risk-adjusted parameters? Let's feed it up. Let's give them the information that we collect that we feel is important. Classification, perhaps. What the clinician's physical performance measures might be important. If I'm talking to a psychologist, they're going to tell me depression is important. So there are many variables. And the whole exciting thing is it's a fluid process, and risk adjustment is growing as well as evidence-based practice continues to grow as we collect more data. Now, if we look at patient self-report health surveys, they also fall into two traditional categories. And first is your paper and pencil. Has anybody done an Oswestry? Neck Disability Index, SF36, pain diagram? This is all I did for 13 years. In the 1990s up to 2002, I didn't realize how much of a burden this could be. You have to score it, you have to Xerox it, you have to file it, you have to start correlating different scores to find out what the heck's going on. Well, I saw the light in 2003, and I finally went into computer technology, and I can't turn back. And I started using photo in 2003. And the reason why I'm so excited by all of this is what Dennis gave to you this morning. This power of risk adjustment. This tool is risk adjusted. That's very, very important. If you don't want to work in a silo, and you can't compare yourself. If you're not going to risk adjust, there's no use talking about your data. It's just no use. You're not going to convince me. You're not going to convince anybody else or a payer or anybody else if you do not take into account different patient demographics. We can make a very simple case. This is Clinic A and you're Clinic B. All right, I want to see who's better. Well, Clinic A sees all sports medicine. Clinic B sees all patients in a nursing home. Well, I'm a payer and I want to know who's doing better. Well, obviously these guys are much better than you. You shouldn't get paid. Well, what's your first response? It's not risk adjusted. And this is what you need to understand in order to compare us. Don't you dare compare us until you understand that. So that's education. We need to educate payers on what they're trying to do in changing reimbursements. So we have to defend and work at what has to happen. Also, quantifying measures of function, I can get very academic here, and I will, really captures the essence of the APTA's 2020 vision for our profession. Have you heard of the APTA's vision for 2020? Well, it's what is it, 2020? Yeah, so have you heard of that? Yeah. Well, what is it? What is our vision in 12 years? Where are we headed? To become competent rehab professionals, which translates into first contact clinicians in a direct access environment. Netherlands is already doing it. So some countries are really hot, and they're doing that right now. And what are we going to do? We're going to demonstrate evidence-based practice, which is what? Well, to perform physical therapy differential diagnosis, because we better sort out the serious stuff from the non-serious stuff, and use interventions based on differential diagnosis. That's what our vision is. So the vision incorporates evidence-based practice. Boy, that word keeps coming up over and over again. Evidence-based practice is what? Every course that I've gone on over the past 10 years and over the past, I guess since 1989, is evidence-based. Everything's evidence-based. What do they mean when they say that? Do you have a personal preference as to what that means? If you're going to go to a course because he says it's or she says it's evidence-based and this one doesn't? Is it evidence-based or not? What is it? What is evidence-based practice? You can't answer. Any ideas? All right. Think of it as a triage. All right? Triage. You're forming a pact with the literature, with your expertise, and with that patient. So it's a triage. You're trying to integrate as much information that you can from the research, from understanding the patient, from your subjective history and your clinical examination, and with your expertise. Because you're going to recognize patterns of symptoms or recognize some type of pattern that you need to start integrating, classifying, and then bringing in the literature to refine your thoughts. So that is the definition of evidence-based practice. Well, I can use this. And that is the integration of best research evidence available with your clinical expertise and with the patient's beliefs, values, and preferences. That's evidence-based practice. IS a la Sackett. And this is the overwhelming operational definition, which everybody kind of uses now. So that's what they mean by that. So what I want to do is slightly turn the page here and look at how I collect information using photo. I collect a lot of information. I feel my physical examination and what I do is important, and I believe what the patient's telling me is important, and I'm trying to figure this all out objectively. So I use physical examination data based on my experience. I set up user-defined questions. Anybody in here use user-defined questions yet? If you're interested in developing TMJ program, a lymphedema program, you need to start using user-defined questions and capturing data to help us grow where we need to grow. I mean, there's a lot of information out there that we just don't know how to quantify, and if we have your information, we can start doing that through user-defined questions. These, for example, there's no place in photo that I can go and click centralization if I feel that's an important physical examination or observation. There's no way I can collect that data unless I start telling the photo, the tool, I need that data. So I create it. I find interest in directional preference. I'm also interested in test results from clinical prediction rules. Does that sound familiar? Clinical prediction rules is basically what we're all hearing about in the low back pain literature. And that's being driven by Julie Fritz and et cetera. So I'm tracking that because it's evidence-based. And that's driven my interest in treatment-based classification subgroups. Again, I'm documenting all of this information because I would like to see more data collected to drive risk adjustment. Maybe centralization is more important than the amount of physical activity or their age. No, not really, but just as an example, there may be important use for clinician-driven data to change the risk-adjusted model. So let's collect that data and let's analyze it. If we don't ever collect the data, you don't have a say too much. So yeah, let's collect it. Now, optional self-report health surveys are equally important. I turn on a heck of a lot of surveys. And I don't have my patients giving me a hard time. Why? Because I've standardized my introduction of what I want from the patient. The patient value equals the therapist value. And if they see you have high value for this data, then they're not going to be as nervous. Why am I answering this question? This question doesn't apply to me. So I ghost the competition. My first 6 months, I had the same complaints everybody else had in here. Why are you asking me this question? This doesn't pertain to me. Well, if you tell the patient in the beginning, you know what? The computer's kind of slow. It doesn't know if you're 10 or 100. It doesn't know how you're functioning. So we're going to put in all these standard questions inside this computer, and they're going to ask every 10-year-old or 100-year-old who comes in here the same thing. So it doesn't know what to ask you, so it's just going to give you a series of questions. Don't be alarmed if something doesn't quite fit you, because you can just hit the closest answer. And the reason I want to use this information is to learn how your pain affects you, so we can develop better treatment goals. And I track who does go on, who doesn't go on. I would say maybe 7 or 8 patients in the past 5 years have absolutely refused. Refused. We'll have other reasons why they don't go on. They don't have the cognition, they don't have the motor skills, or they're Russian. I don't have a Russian version. So language is a problem. So there are problems. Or they arrive an hour and a half late for my appointment. Hey, okay, I'll turn on the non-participation order. I can't handle this. I have other patients to treat. So I track that reason, though. All right, so I try to keep track of why patients can't take it. Now, it's not about Mark and how I use photo. What I really wanted to emphasize here is that photo is a tool driven by the clinician. You select the tools based on your knowledge of what you need to understand that patient sitting in front of you. And I'll tell you what, if you're in a chronic pain management center, are you going to use the same tools that you're going to use in primary care or with an acute occupational type of patient? Would you use the same tools to ask them to fill out? You better not. And you better know which tools to turn on. For example, has anybody in here heard of the DRAM? The Distress Risk Assessment Method. One of the best tools psychosocially to understand how distress influences patient outcomes. Okay? And it actually classifies you, or classifies the patient at the level of risk. It has been shown over and over again in head-to-head competitions with other tools that this is the best. But regardless of that, it doesn't apply to primary care. I'm not going to ask my patients 40 questions about why they want to kill themselves or why they're having problems doing this or that. It's inappropriate. You have to make sure you're in a multidisciplinary center to turn on certain tools. So again, knowledge of the literature helps you make better educated decisions on how you're going to evaluate that patient. You have to understand what they're thinking. You can't use subjective history to understand fully all the concepts that are in that patient's mind. Distress is a socially sanctioned, or I should say pain is a socially sanctioned idiom to tell you that they're freaking out. They're just going to tell you about their pain. I'm coming here because I have pain. But that's not maybe the real issue of why they're seeking care also. Maybe it's being driven by other processes or constructs that you have to kind of peel the onion down to see where we're really going here. Okay. Evidence of effectiveness, again, I've already mentioned. I have an interest in classification of specific subgroups. And that's basically using your physical examination data, patient subjective history, collecting a cluster of signs and symptoms, making a classification to help direct treatment. Is there evidence out there? Sure, there's lots of it. Just long is one, 2004 spine. We have Brennan, spine of 2006, and I can go on and on and on. But what's curious is, well, you know what? We still have to learn much more about patient classification. We don't know enough. So if I want to pick on the Brennan paper, for example, over 1,000 patients were referred during their study to many, many clinics who were participating in this study. All patients referred to this clinics, only 25% were able to be classified. So what do you do with the other 75%? Punt? No. You could apply other classification techniques, or you could rely on current clinical practice guidelines. There is enough evidence, and a really nice example just came across this summer by Fritz, spine of 2008, where she showed that clinicians who were adherent to current clinical practice guidelines, okay, were much more efficient and effective than physical therapists treating similar patients not adherent to current clinical practice guidelines. And then if you want to take it up a notch higher, if there is an appropriate classification for that patient, there is evidence now that if you treat according to classification, you're even going to do better than the clinical practice guidelines. So you have to know what's available out there and match that to the person sitting in front of you. And that's an effective way to start this evidence-based practice. And what is current clinical practice guidelines? If you're familiar with the literature, I think John already went over it. Avoidance of passive modalities, active, function, and cognitive behavioral techniques. What is cognitive behavioral? Is that a dirty word in manual therapy? Cognitive behavioral? No, it's not at all. Cognitive behavioral is what we do. Do you ever reassure a patient that things will be okay? Do you ever empower the patient to try to get into self-care? Well, then you're a cognitive behavioral therapist. All right? There's nothing wrong with that. These are very simple techniques employed by us, and we don't even label it, but they are important. It's part of the MDT. Empowerment is a very powerful construct within the MDT philosophy, let's say. So, again, cognitive behavioral can be as simple as reassurance, and I'll get into a couple of examples where it can be quite formal. So if you're in a chronic pain clinic, you're going to want to turn on some CBTT programs. Okay, let's go forward. You know, there's a caveat that I found very interesting when I read about these classification systems by DeLito and Brennan and others. The caveat is that, you know what? You know, we came up with this great algorithm and we think this is the right treatment, but there are still intrinsic or extrinsic factors which favor or do not favor success. One of them is fear avoidance. Well, I thought that was very curious and really very interesting, because other evidence from other professions and other organizations are telling us that we need an integrated classification system that will allow us to better understand or get a more rational assessment on non-specific lower back pain. I'm picking on low back pain because that's what I enjoy. So, and a lot of this has corollaries to the other extremities. But a rational assessment of non-specific lower back pain. When I use the term non-specific, do you know what I'm already geared towards? I'm ruling out what? Serious spinal pathology, red flags. I'm ruling out true nerve root pain. So I'm really kind of picking on mechanical things, things that we commonly see. All right, so we need to understand from a rational assessment about this, and it has to be an illness. We're a whole body person, so we need already to turn on multiple constructs. You cannot understand a patient if you're not listening to multiple or objectively defining multiple constructs. And that leads us into the strong push, and it gets stronger and stronger every time I read clinical practice guidelines. They don't seem to change over the past 5 to 10 years. They're encouraging us to understand the patient's pain from an illness presentation. Well, the World Health Organization comes along and says, well, we're going to support biopsychosocial, but we're going to change the name, we're going to change the category. Now it's International Classification of Disability, Function, and Health. They're going to use different terms, but instead of using illness, they're going to say, you have to understand that whole person sitting in front of you. Again, turn on multiple constructs. You need more data. A statistician, if you're going to handle risk adjustment, you need more data. Well, clinicians do too. So if you really want to understand your patient, you're going to have to upgrade the game. You're going to have to know how to take the next step. And the only way you can do this is to have more data. So that leads us from a biomedical model. That's what I was trained in as a physical therapist. And I think that's traditional and it's classic. You know what I found really interesting is when Tamara, said her new therapists were getting hired because they had an interest in evidence-based medicine. I never heard that before. Most people heard evidence-based medicine, you have to collect data, they're going out the other way. So the DPT program has made a difference. This is how we need to think. We have to start including the literature into our decision-making. So I found that very fascinating. And as a matter of fact, I skipped my slide. I started going so fast. So we're going from a biomedical to a biopsychosocial model. Now, again, the biopsychosocial model, if I were to go to a manual therapist group, I'd probably be pushed out of the meeting, only because I feel there's been a misinterpretation here. Biopsychosocial is a spectrum, truly respects the importance of biomedical, truly respects the importance of your physical examination technique to understand underlying pathoanatomical dysfunction. That's important. We better do that because we want to understand the patient from that perspective. That's what we do. The biopsychosocial model says, yeah, keep doing that. Let's keep looking at research to understand this. Let's keep validating patient subgroups, etc., but also be open to perhaps that there may be other things going on. So the next slide really kind of looks at the biopsychosocial model from a very practical, clinical point of view. Okay, so you're my patient, and we're coming in. I'm going to do an evaluation. Well, what am I going to be very interested in? I'm going to be interested in anatomical dysfunction. So I know these certain tests. I want to tell if you have a labral tear or a rotator cuff. I have to do all these differential clinical diagnostic tests because I want to get an idea of anatomical impairment. Important. Biomedical model states to do that. And if I do it right, and I pick the right tests out of the 15,000 other tests for the shoulder that are in there, then I should understand the patient's pain better and their level of dysfunction or disability, right? Does that make sense? Isn't that how we would work it? Well, that's what the biomedical model is saying. There is a linear relationship between these important constructs. Okay. Biopsychosocial model says, yes, you are correct. Keep doing that same evaluation. But think outside the box. These constructs may not be linearly related. That's a very powerful statement. They may not be linearly related. I do everything right and the pain decreases, my function doesn't change. Photo's no good. I heard that over and over again. Is that true? Well, maybe from a biomedical construct it is. But we're into a biopsychosocial construct where linear relationships no longer exist except for small subgroups of patients. You'll see it, but you're not going to see it every time. Now what I would do, next step, is step back and put the patient inside Pandora's box. And what is that? Well, that's my term. That's not an evidence-based term, but that's my term, Pandora's box. Because there are many, many layers of intrinsic and extrinsic factors which you kind of have to be somewhat aware of if you're going to understand patient outcomes. What are these? Have you heard the term yellow flags, blue flags, black flags, green flags? All these flags. So have you heard of these terms? I'm not too familiar with them. Well, how about psychosocial factors? These are yellow flags. This is actually way back when from the New Zealand guidelines. They kind of really took the horn here. I think it was in the early 90s. And they started using these category yellow flags, or psychosocial factors. What are psychosocial factors that we should be concerned about? Maybe the patient's anxiety, fear. Is depression something we should be concerned about? We'll talk about it. Yeah, maybe it is. Okay? But these are only potential confounders. And that's a difference. It's potentially a confounder. We're going to talk about the fear avoidance model to see why it's potential. Blue flags. Okay, you're an OCMED. And you're very interested in return to work. But you're not paying attention to the patient's job satisfaction, the employer's return to work policies. You're going to do everything right. And the employer says, well, you don't know what the hell you're doing. Your return to work is 20%. That's because the employer is setting up all kinds of obstacles that they have to be at 100%. They don't believe in light duty nor transitional programs, and they don't have anybody on site. So you have to educate. You take that information and you change the employer's policies, if you can, or educate them on how they can run it better. And you're going to see your return to work rate go way up high. Why? Because you understood the importance of blue flags and tracking patient outcomes. Black flags are a little bit more ominous. I don't know if private practitioners in private clinics see black flags, but I see a lot of them. I work in a hospital, and that's Medicaid. They're there. If I have somebody who's seeking Social Security disability or is on Social Security disability and they want to make sure they stay on that, I think I can be efficient with that patient. I don't know if I can be effective. So you have to use that information carefully to determine what you can and cannot do. So black flags, as they're labeled black, maybe more of an ominous sign. You should be aware of that. I mean, somebody seeking Social Security disability, they're going to love you if you treat them for a year. They'll be your best friend. But is that what we need to do? I mean, John mentioned this morning, if you can't help them, maybe they should go elsewhere or be referred somewhere else. If there's nothing too serious, well, maybe there's a different plan. Green flags, well, this is kind of the good stuff. Centralization, directional preference, multiple criteria on a clinical prediction rule. These are kind of helpful in understanding that, hey, this patient's going to do well. Now, since we have time, there's no questions yet? Since we have time, and we have lots of time, I want to start getting more nuts and bolts about a biopsychosocial construct. So I'm going to bring in more data. You have to understand more information. So we're going to just pick on one area. We'll pick on yellow flags today. So I'm going to introduce you now to the fear avoidance model, which is a component of, this is one construct, but it's helpful to think about this with other constructs of physical examination and patient's pain and their ability to function. We need to know more information. Dennis brought this up a couple of times, so I thought it would be good to reinforce this. Why is this important? Well, the fear avoidance model has, by the way, anybody hear the fear avoidance model? Good, okay. Provides compelling scientific evidence supporting the assessment and treatment of patients with elevated fear. So if you turn on the fear avoidance of work, let's say, and the patient has elevated fear, there's evidence suggesting that those patients, your treatment, you should augment your treatment with your conventional treatment with strategies suggesting cognitive behavioral interventions. You can do it informally, or if that's not succeeding, you may want to introduce them to an operant-graded exercise program where the patient's exercise is progressed by physiological principles, not by pain be your guide. Okay? Or you could use exposure in vivo type of program. This is by Vlayen et al. This is kind of interesting because it really fits in sweet with photo. And this is the one I like to use. Because photo prints out a hierarchy of functional limitations on the right side of the page. Well, all you have to do is go and set up a hierarchy of where they're having difficulty. Well, I can't lift groceries. Well, then what you need to do is expose the patient to lifting groceries during your session. And then what you try to do is rephrase the patient's or rechange the patient's perception of hurt versus harm. Well, you just lifted up the groceries and you said you can't do that or you have extreme difficulty. Well, do you think it's easier now that you've been practicing squats and you're doing these exercises? Yeah, it's getting easier. So you would expect to see a change in their ability to do usual normal activities on the functional score. So you better tap into using photo on a serial basis to see if in fact you're being effective. You can't understand treatment really until you see the outcome. And if you wait to discharge, it's too late. You might have missed the most important active ingredient. So again, serial assessment over time is important. Now, I skipped ahead. I must be touching this thing. Let me just check. All right. Now, to appreciate the fear avoidance model, I better put this down. I'm just clicking away. To appreciate the fear avoidance model, you have to have knowledge concerning the patient's and the clinician's beliefs and fears about pain. All right. Now, it's easy to get the patient's pain beliefs. By the way, we're going to test your pain beliefs next. So you have a piece of paper and pencil. We'll get that out. But to start assessing your own pain beliefs, we have to take a different approach because it's important. The literature strongly suggests that the clinician's beliefs and fears about pain will enhance or diminish patient outcomes. So maybe you're driving poor outcomes on your photo and not even knowing that perhaps how you're managing that patient from a different perspective may not be helpful for you. So, for example, when does pain merit disability? Depends on what profession you ask. Will your attitude about pain, affect your treatment choices? Will it? Can you change your practice behavior if you're a dedicated manual therapist and this patient is high risk based on psychosocial factors? Can you change practice behavior and change treatments for that particular active ingredient? Well, let's find out. Now, Linton developed a very interesting 14-item questionnaire to quantify clinicians' pain beliefs. So go into the end of my section, and you're going to pull out Linton's pain belief questionnaire. And you're all going to fill it out now, hopefully. It's only 14 items. And it says, please answer the following questions. You got to do photo. This is paper and pencil. I love it. Okay, here's your standard instructions in which you are now going to comply. So please answer the following questions. The questions are related to the most common forms of back pain. We do not mean pain related to fractures, infections, cauda equina syndrome, tumors, or to nerve root injury or pain. So take 5 minutes and just circle whatever you think. Don't try to think what the right answer is. Just put down what you feel is the right answer for questions 1 through 14. We'll take 5 minutes, then we will score it, and then we will interpret it based on Linton's suggestions and data. Everyone done? All right, so we'll score it. First, we're only going to score the first 7 questions. So on question number 4, before we do the cumulative score, I want you to reverse your numeric answer for question 4. So if you had circled 6 for question 4, you're going to add it up as a 1. If you circled 5, you'd add it as a 2, etc. Okay? So reverse your score for question number 4. Okay, next, add up all the numbers for first 7 questions, and then divide that score by 7. I haven't done this since grammar school. But I don't have a calculator, so you just do the best you can. You know, the highest possible score you can get is a 6, and the lowest possible score is a 1. So if you're outside of that, check your math. Well, it's only 1 decimal point, right? So what's 10,000 versus 1,000? That sounds political, but we won't go there. So again, reverse question 4. Add up the first 7 questions, divide by 7. All right. Now, how many in the class scored 4 or higher? Just raise of hands, high as you can. Raise of hands. 4 or higher? 1? Do I hear 2? 2? Okay. Here are 3? That's it? Just 2. How many scored between 3 and 4? Oh, real high. So, okay. And how many scored less than 3? Whoa. You guys collect outcomes. That's pretty good. I usually see a more even distribution, but this is like sometimes preaching to the choir, especially if you're interested in collecting outcomes. Now, how do we interpret that a la Linton? Clinton, a mistake. If your score is 4 or higher, you're considered high-fear clinician in the sense that you're more comfortable with the traditional or biomedical concept of pain, where reduction of pain is a prerequisite for activity. Rest and sick leave would be prescribed, or you feel more comfortable with a patient doing that. And identifying high-risk patients for developing chronicity would be more difficult. If you scored less than 3, then you're in tune with the biopsychosocial model. Here, you would be following more of a current clinical practice guideline setup for education, self-care, return to activity, hurt versus harm. You'd feel more comfortable with those constructs. If you score in between, then you're in between. But Linton didn't really discuss that. So the idea here is that clinicians have different fears and pain beliefs within themselves, which are translated sometimes to patients. So let's look at 3 papers which kind of review what we observed. Now, Linton applied this same test to a wide variety of different clinicians, physicians and physical therapists. Physical therapists were more skewed to higher and lower. I mean, this was very few 4 or higher. Most were below 3. In the physicians, though, there are many who were in high fear, or many classified into low fear. So there's a wide variability. And is that variability important? Maybe. Dakin, just a couple years ago, found that physical therapist pain beliefs influences 3 major constructs, and that is your clinical reasoning processes, your explanation given to the patient regarding causes of pain, and your management of that patient. And just this year, Fullen did a systematic review looking at specialty and MD personal beliefs and how they impact acute lower back pain. And they found great variety. Is there any physiatrists in here? I don't want to pick on anybody. Physiatrists were embedded in the traditional biomedical model. And if you see scripts from physiatrists, they're loaded with passive modalities. They're loaded with, hey, you can't go back to work yet. They're loaded with, come back and get more injections. So as a group, physiatrists show the largest variations in practice away from current clinical practice guidelines. Why? You just start looking at their medical model and how they were trained. They can't get out of that and start incorporating other constructs to make different decisions. That's basically what they're finding. So, taken collectively, these studies indicate that the clinician's attitudes and beliefs about pain can be directly or indirectly expressed to patients, which perhaps can play an independent role in the patient's recovery or disability. So it starts with the clinician first. You have to understand what you're saying to the patient. Is it important? It may very well be. This is a very interesting study about that. Medical diagnosis. If we are becoming first contact clinicians, you better be very careful about what you tell that patient. Here's an example. This was a physician's medical diagnosis without imaging, collaboration, or anything. This was my initial best guess for you, based on you sitting down, you've had back pain for 7 days, you're coming in for your first contact. And I say to you, boy, I think you have a disc lesion. You know that? And I think it's so herniated that pain's just running down your spine. And, well, maybe you have some subluxation and some other bulging disc going on in there. It doesn't look good. Well, you think that's going to influence the prognosis? Oh, it strongly will. Labeling your patient with scary diagnoses and telling a patient they have a herniated disc is going to raise the level of fear, and you're going to really start creating iatrogenically disability. 5 times at risk at 2 years. If the person was a little bit older, maybe they respect the medical profession very highly. You know how it is when we were older, authority was really important. 10 times higher risk of disability at 2 years. Compared to that doctor saying, well, I think it's lumbago, sprain, strain. You know, it should get better. So telling patients, unless there are signs of serious spinal, you maybe have to do differential diagnosis here. It's not winging a prayer. If you're seeing serious signs of serious spinal pathology, and if they have foot drop, you tell them the truth and you level with them. But if you're not finding serious signs, your differential diagnosis leads you to non-specific, then don't tell the patient, well, maybe we should do an MRI and find one of those false positive HMPs. You've got to be careful, because you will create iatrogenically disability. So it is important what you say to your patients. Now let me clarify that. If this patient has no distress, no fear, and let's say a white-collar worker or whatever worker, and they have no fear, hey, I have my pain, doc, what's going on? You can tell them the Webster Dictionary and explain every little feature on that spine model that you want, and you're probably not going to drive this person into a problem of overdiagnosis, because they want to know that. There are patients that way. They want to read books about this stuff. So what? Do it. If that patient has been classified at high risk of fear and distress, you tell them this, and you're driving the nail into the coffin, because you know how many patients come to you with 15 MRIs. You've got to read this. I'm in bad shape. You don't touch me. Did you read that report yet? Why are you telling me to bend over? Haven't you seen that? You must have, if you're dealing with low back pain patients. And I tell them, well, I don't really need to read. Let me do your clinical exam. No, you better read. So, okay, I'll read this. So I look at the radiology report. Okay, let's get on with the clinical exam. And then I discuss later on, after the evaluation, if it correlates with the clinical exam. And then we proceed. Okay. I like kind of flow things here, like the biopsychosocial model. So I think the best way to understand the fear avoidance model is with this display. Okay, fear avoidance model. Best way to understand this is FABQ, by the way. Okay, that's fear avoidance model, fear avoidance belief questionnaire, et cetera, et cetera. Okay, patient experiences an acute onset of pain. They have 2 pathways that they can follow. If they believe that there's something seriously wrong, by the way, patients are seekers of care. Only 25 to 30% of all patients experience low back pain become care seekers. So what's the difference between a care seeker and a non-care seeker? It's usually the level of distress and fear about why they're having pain. So the patient comes in and they feel there's something seriously wrong, so they start to catastrophize. They're really worried. Anxiety levels are very high. If this is not taken care of during the first encounter, fear of pain and anxiety increases. And over time, the cycle goes to avoidance and escape. As little as 3 months has been defined as chronicity. The 3 Ds of chronicity are disuse, depression, and disability. And then the cycle wraps and gets tighter like a hurricane. The eye forms. They're out of work for 6 months. 40% chance. They're out of work a year. 25% chance. They're out of work 2 years. You have a 0% chance almost of getting this person back to work. So getting that patient out of that cycle would be very important. Now on the flip side, and by the way, they would be classified as avoiders. On the flip side, they do have fear and some distress. They have an acute onset of lower back pain. You're the first contact, and you're able to, based on your examination, to reassure that patient that there's nothing really to worry about, that they will get better. And you empower that patient. You start teaching them hurt versus harm. They confront their pain and are able to return to activity a little bit easier. Even though they have pain, they can still start modifying, controlling pain as they return to activity. And again, this is the literature. It's not my opinion. So those would be considered confronters. So would it be important when you have a patient sitting in front of you to know which pathway they're in or which pathway they're going to go to? I think so. So you've got to understand that. Now, within the fear avoidance model, it was not just fear, was it? It's catastrophizing. Somatization would be another term, depression. These are important issues within that model, and these may be driving the model stronger than the fear. But catastrophizing is, this is where they're really exaggerating the threat value of pain. My spine's going to fall. I can't do that. You know, they're really afraid the threat value of pain is very high and it's serious to them. Somaticizing, if you've ever done a pain diagram on a chronic patient and you see you start looking at what's not shaded in, you know, where are you going? How are you going to evaluate all of that? You have to understand that's a level of distress. The patient's trying to communicate something to you, and you need to understand that. And depression is in the geriatric patient population, again, seems to be a social, discussing pain is an idiom or socially sanctioned idiom to tell, I'm really depressed and distressed. You need to key on that. So these are important things to start thinking about. Why? 33% of patients referred to physical therapy have clear signs of, documented signs of elevated, you know what, there's a button back here. I must be pressing that. Clear signs of distress. Again, a nice example here is Karn Spine 2003. You know, as manual therapists, we're very strongly interested in clinical practice guidelines that look at clinical prediction rules. Well, only 20% of our patients seem to fit that. Well, here I have this depression, 33%. Well, should we be interested in this subgroup? Well, if we're first contact clinicians, we better be. We better know how to screen for that so we can refer that patient. Now, not every distressed or depressed patient requires referral. And I'm going to show you an example of that because these are potential confounders. Only potential. And over 2 to 3 weeks, as you do, that's the value of serial assessment, by the way, photo serial assessment. You can start seeing change in other constructs to confirm that, hey, I'm on target here. My treatment of exercise or manual techniques is also relieving this patient's distress. Well, that's a good thing, right? And that's what you want to watch for. But if it's not, I'm not sure how effective you're going to be after 3 or 4 weeks. So why is knowing elevated distress important? Because there's overwhelming evidence linking distress to severe limitations in daily functioning. Poor treatment outcomes and prognosis. So here you are as a clinician working on your construct of physical examination and treatment based on those tests, and you're not getting the functional improvement. This is no good. Perhaps if you looked at other constructs and potential confounders, it may become obvious that with this level of distress fear avoidance, maybe you're not going to make a difference. And maybe something else needs to be tried. So again, looking at and developing skills and collecting data from a biopsychosocial perspective or spectrum may become increasingly important. Now, I just wanted to throw this in too, because if you're a distress fear avoidant, now you got both high factors, then you're 2 times at higher risk for a poor outcome than if you were just fear. So my challenge, and Dennis and I have talked about this a lot, and risk adjustment is a fluid process, but it hasn't yet put into the model depression. and how depression links with fear. So there's many other areas that we can see and grow, perhaps, and understand our patients more. But we need more data. Data drives the risk adjustment. The clinician can drive the statistics, but you've got to be willing to collect the data so we can understand what's going on with our patients and make better decisions. Again, I'm showing you how to use data to demonstrate evidence-based practice. So it seems more complex, and the more you get into it, the more complex it is, and the more humble I feel in understanding patients sitting in front of me, even though I've been doing low back pain for 30 years. Each patient is unique, and to understand that patient requires more data. So you have to have tools to assist you in data collection so you can think on your feet. And this is what evidence-based practice is. So I have 2 case studies now that I wanted to go over as a practical example of a multiple construct evaluation and multiple serial photo assessments so you can see how things change or do not change. Okay? So hopefully by collecting more data you can effectively manage your patient. If you know you can't be effective, should you be efficient? John this morning said yes. The ultimate goal is to be effective and efficient. But if you can't be effective, you better make sure you know why. Besides, I don't like this patient. Oh, Mr. Smith's on my list. Well, you better understand why, just from your own personal preference for a personality, of why this patient is not progressing. And what are the objective data to support a discharge after 8 visits, 6 visits? Can you do that? Should you do that? Or should the patient stay in the system for 6 months until, well, you've tried everything else, nothing's working? So again, using data to make decisions is very important. Okay, now, before I even see the patient, they're going to do photo for me. All right? I give them, they actually come back in the examination room, or I have them come in, by the way, 20 minutes early to try to fill out their photo. So I am a data hog. I don't want to lose time in evaluating my patients. I really work hard with my upfront people to make sure they're told to come in on time. If they're 10 o'clock with me, their appointment time is 9:30. And it seems to be useful in ghosting the competition. So to get that patient in there early, because I want this information. So in this case, it's 9 o'clock, and the patient has filled this out for me. So before I even say, hello, Mr. Smith, I know that this is an orthopedic lumbar, 55-year-old female, Spanish, moderate disability, no surgeries, less than 14 days, workman's comp, 1 medical comorbidity. They have high fear and distress. Now, I also have turned on optional surveys, and I'm going to get to this, but the SCLR is a quick questionnaire to start measuring depression and somatization. Now, we have 4 other people who are working with us in this type of data collection, and I haven't heard a lot of difficulty collecting this information. Bill, have you had trouble? John hasn't had trouble either. I had one therapist who did, and he dropped out of our group. But for the most part, if you explain why you're collecting this information, you can be very successful. And you want this information because you need more data to understand how this data can affect your outcomes. You can't help everybody, and maybe you can start understanding why the photo score doesn't go up. So this is what I have in front of me. I know this person's in high distress. This is an acute patient. I expect them to be in high distress. They have high pain. Okay, let's do our physical examination. Let's sort this patient out. And again, they have acute onset of constant lower back pain, diffuse left thigh pains. So we start the physical exam. My training is on MDT, so my repeated movement testing today during the initial eval is inconclusive. I don't see any directional preference, centralization. By the way, this is all nonspecific. We've already ruled out red flags, and there is no neurological signs. I use the clinical prediction rules now. Well, now I'm seeing hypomobile lumbar segment, hip internal rotation greater than 35 degrees. These start to become criteria from which to start establishing classification subgroups. Negative prone instability tests, negative aberrant trunk motions, negative straight leg raise, negative neuro. And in the background, I am aware that this patient has elevated fear and I'm aware that this patient has distress and it's a work compensation case. Do I overreact and be terribly concerned about that? No, not in an acute patient. Let's apply the treatment. Let's apply standard, rational treatment based on evidence-based, and let's go. So if we were in the decision-making algorithm of DeLito et al. Or Brennan, how many people like to use that classification system? JW? And, yeah? Okay. So this patient falls into the second tier. The first tier is looking for directional preference in the Brennan approach or DeLito approach. The second tier, what we have here is 4 out of 5 criteria suggesting manipulation. So this patient, let's say, would receive manipulation based on the evidence. And it doesn't fit in with this stability group. Okay? So that would be a decision-making algorithm for Brennan or DeLito. For example, if John were here and he were to classify his patients, they wouldn't fit the 3 syndromes. They would end up being mechanically inconclusive on that first visit. By the way, there's a lot of overlap between these 2 classification systems. The central theme of both classifications is driven by centralization to directional preference. Probably the primary difference between the 2 systems is the tenacity at which MDT-trained therapists will search for directional preference. They may take 1, 2, 3 visits before they feel they can sort the patient out, which may be the case with MDT. But in the DeLito system, it's more perfunctory. It's more of a, okay, hit, no, okay, let's go on to the next criteria. So there are striking similarities and yet striking differences on how they classify patients. And hopefully more research, we can get some head-to-head competition looking at that. That would be fun. Okay, interpretation of fear. I collected the fear data. We better know how to interpret it. Okay. Well, photo's getting a little bit smarter because they used to didn't do this, but now they do. They put a little red flag up there. If you've seen red flags by the fear question, well, that red flag means it's elevated. Yeah. Okay. So how do you interpret that? That's the physical they're going to show you. Dennis puts from 0 to 100, so the number in the parentheses is the literature interpretation. So if they're at 15 or higher, the physical side, you can consider that high fear. And the paper Dennis mentioned earlier was the paper we have in physical therapy right now. It's under review, 2008. But single items of fear avoidance. So we've used CAT processes on this fear avoidance. So we can try to break down the burden of the clinician and the patient by only asking one question. And that one question can turn on the survey or turn off the survey. So it's now a CAT process. Well, that would be sweet if we could do that for many other important constructs like depression or catastrophe. If we could turn on one question and show that's a valid way to assess depression, man, that would make our life simple instead of having to do the whole SCL90R. So that's things that are coming, but that's the power of the CAT. All right? So we have to tell the statisticians what's important so that they can start refining the statistical analyses. Now, if I were to swing over on the other side, anybody uses the work subscale? I know the physical is regular on the photo, but the work is an optional survey. If you're working with Ahmed and anybody less than 65, non-students, etc., it's probably valuable to turn this tool on. I mean, if you look at George's and Fritz's work, this tool is probably even more powerful than the physical belief scale. So the cutoff point for understanding high fear is 30. It's a maximum score of 42. So if you see 30 or higher on your photo, then you can consider that elevated fear of work, which may or may not have to be considered. Now, I've also brought up depression and somatization as part of the fear avoidance model. Well, this is how you can measure it. You have optional surveys in there looking for depression and somatization. There's an awful lot of literature supporting the use of those scales in primary care. And this literature comes from Dionne's work, but strongly supported by Rosignol. Anybody hear of the CLIP, the Canadian Clinic on Low Back Pain and Interdisciplinary Practice? They say, based on multidisciplinary experts and based on the evidence, you know what? Therapists or clinicians, not just physical therapists, turn this on. If you're going to be a first contact, I want you to turn on this screening method. All right? Because we've got to understand this also. And how do you interpret it? Well, the analyses have already been done by Dionne, but as far as the photo scores are concerned, I would start looking at a score of 4. So if you have somatization depression and the total score is 4, I would start to be somewhat concerned that this may be a confounding factor. Or if the depression score alone is 3 or higher, then I would be somewhat concerned that this may be a factor from which you have to understand how effective you can be. But by turning on serial status assessments, you're going to know if this is just a potential confounder or something that patient needs to have addressed in order to continue being successful in your functional rehabilitation. So those are general scores. Analyses are ongoing. We're still collecting this data. Hopefully next year we'll have some more specific information on this interpretation. Okay, now I have that basic information. I would assume acute patients. We don't want to create iatrogenic chronic patients, so the literature suggests we are very quick with acute patients and we don't overtreat. So, serial assessments on a regular basis would help confirm, can I help this patient or can I not? Is this a responder or a not responder? Not necessarily mechanically, but from a whole person perspective, from the international classification of the World Health Organization, can I help or not help this patient? Well, here's the data. Week 1, wow, 33% reduction in pain. Pretty happy about that after 1 week. My treatment is doing well. We'll do that. Manipulation must have really worked. In the backdrop, this patient's score has gone from a 47 to 45. Well, okay, so what? It's just started. Let's keep working on this person. The fear is somewhat decreased. Fine. So we continue our treatment. The next time I do it, well, now I'm seeing that, well, yeah, we still have 33% reduction, no significant change in function, and then I still have this distress fear avoidant patient with me. Maybe I better start augmenting my treatments with other strategies. Maybe the active ingredient isn't physical. Maybe I have to work over here. So perhaps, again, empowerment and other practicing functional activities in the clinic, what have you. Again, when the patient comes in each visit, you have to start deciding how that patient has changed between each visit. Remember the utilization index? That is a powerful indicator of overall performance. Each visit is important. You want to maximize that patient's return to function during each visit. If you're not, why not? Do you have to change your treatment strategy? Or do you continue doing the same thing until they're discharged? Oh, they didn't do any good. Okay, well, it's too late. So serial assessment gives you data to think about confirming or changing treatment strategy or discharge. Well, 3rd week, the patient's going back to see the doctor. Distress fear avoidant. I've gone from a 47, I'm now at a 39. I'm not doing very well. I thought I did very well. I followed the clinical prediction rules. It's just not working out. I yet have 50% reduction in pain. So I have a very happy customer. Usually, by the way, if you see 50% reduction in pain, your satisfaction goes way up. Just satisfied. But what to do? Do I keep treating the patient knowing that there's no serious spinal pathology, there's no true nerve root pain? How long do we treat this patient? Well, according to the evidence for a distress fear avoidant patient, we should recommend return to work. The doctor may want to consider more formal operant-graded exercise type program. It's up to the physician. In this case, the patient was discharged and returned to work. Light duty. The employer had a light duty transition, so she had a month of light duty transition into full duty. This patient's still working today. Maybe we didn't resolve all her issues, but she knew how to control her pain. I didn't succeed in function, but I understand that maybe if I continue to treat, and I'm a physical therapist, not a psychoanalyst, and if I'm not making a difference on potential confounders, then maybe I need to cut the cord and say, yeah, well, maybe I can't help you right now. But I certainly let the physician know that this patient has significant, or not depression, but depressive symptoms. I don't diagnose, but I'm going to say that there are depressive symptoms that maybe should be considered. I don't know what they want to do with that, a medication or what have you, or something that they want to monitor, the family doctor. But there's a case of understanding, I'll call it my failure. All right? I didn't improve my function. But I'm not overly concerned about that because not everybody behaves this way. And so we'll go to another case. So it's 10 o'clock now, and now I'm looking at another case. And I picked this case because it's very similar to the first case. And then again, whoops, I'm sorry. I threw in something I forgot I threw in. Interesting. Okay, take that back. It's not 10 o'clock. It's still 9 o'clock. So I wanted to go over pay for performance. This is one proposed reimbursement model among many others. And we had collected data, and this was led by Dennis et al. No, Dennis and Connolly. And we were trying to look at how we could modify reimbursements for patients, okay, based on the data that we collected using photo. And there are 3 hospitals that participated in it, us at Central State and 2 hospitals in New Mexico. So we had a large number of data. And what they did is they built a reimbursement scheme. I think there were like 9 different outcomes of reimbursement based on efficiency and effectiveness. Effectiveness was your photo score, your change score, FS change score. Efficiency was the number of treatment visits you did. And these were compared against the mean predicted for similar patients in the database who fit this risk adjustment on the top. So this was your risk adjustment. This was patient A, and it went into the database and said, you know what? These are similar patients in the database to this, and the treatment for those patients, they got better by 19 points over 7 visits. Wow, that was embarrassing. I mean, I got minus 8 points, and I decided some efficiency might be in hand, and I did it in 6 visits. So what does the algorithm say? I don't get paid? No. Sure, you get paid, but you're not going to get a bonus. Matter of fact, some say that pay for performance should be budget neutral. You shouldn't be penalized per se, but you're not going to be rewarded either. And if the economy goes down and tanks everyone 10%, you're going to be part of that. But if you're getting better outcomes, perhaps you're going to get more money. So that's how it was kind of scaled in different ways. And it was a beta study. It has promise. But you know what? It teaches me something. You know what? They didn't take into account distressed risk or distressed fear avoidant patient. So maybe risk adjustment, if they consider other variables, might be improved. And maybe I won't be slammed as hard in this case. But this is how things evolve. It's the beauty of risk adjustment. It's the beauty of evidence-based practice. As you get more data, you become better decision makers. And that's what we're trying to do. We're trying to drive dentists to start collecting even more data, even though clinicians say we need less data. But I think we have to work together and look at what's important. They see through our eyes and the data we collect. So let's give them the data. Okay, now I can go to 10 o'clock. All right, here's 10 o'clock. Another case. And this now is a similar patient to 9 o'clock, or case 1. And this is a 42-year-old male, severe disability. Again, no surgery, 14 days acuity. This is a workman's comp. 1 medical comorbidity, high fear. And you notice I did turn on the SCL 90R. And so this profile is very similar to the first case. Okay, high fear, distress, pain level 9. They're in a lot of anxiety, which I would expect is acute patient. Well, let's sort this patient out now through my physical examination. Well, now things start to change. Classification changes. The patient changes on how they respond to physical examination. And in this case, doing repeated movement testing, we see that the patient may be classified differently because they show a centralizing response to repeated movements. There's a directional preference. And actually, since that's a central theme of multiple classification systems, you may end up treating the patient similarly, prescribing exercise that matches directional preference. That's a key to the Lido system and the McKenzie system. So that's what you do. And in the backdrop of your conventional treatment, you better pay attention to the distress and fear avoidance. But they're only potential confounders. And each case is individual. So now you go along and you do, I recommend, weekly status reports on an acute patient. You're expected to see change. If you're not, you've got to figure out why. Well, in this case, wow, this patient did really well quite rapidly. The distress decreased. The fear decreased. And obviously, the pain decreased. And we're pretty hot here. We see a 30-point improvement. Second week, the patient, I am happy. I'm going back to work. And this is a good case. Patient just went way up. And we see this. This is something, if you see very strong centralization response and they remain better, what we see is a quick, rapid change and an improvement in function. If you're centralizing and you're not seeing an improvement in function, I would recommend that you start exposing the patients to function. Remember the three constructs: anatomical dysfunction, pain, and function itself. Well, those are three constructs that need to be included in your treatment repertoire. So if you're seeing some good stuff over here and it's not translating to change in function, then you need to incorporate that into your treatment strategy. Okay? And if this distress continues and it were a chronic patient, then I suggest that your treatment strategy consider operant-graded exercise programs or other types of cognitive behavioral techniques. They seem to be effective in complementing your traditional conventional treatments that you think are important for this patient. So if we were to turn on pay performance now, this might be pretty interesting. So we compare that cell, that patient risk-adjusted criteria, to what's in the database. Do you understand that comparison? So you would take this particular patient, and there are, 2 million patients in the database, and you're going to pick out all the cells that are equal to that, and now you can make a comparison. Your outcome compared to what was predicted for that group of patients based on risk-adjusted comparisons. And this patient should have got better 25 points over 7 visits. Well, in this particular case, we were effective and efficient. I turn on the Hart-Connolly beta study model, and I make out. Okay, I do better. Again, this is only one scheme. It's a pay-for-performance scheme. There are many still out there. I think this one still has promise, and we're going to keep working forward. I mean, you could be your own. You could create your own scheme now. I mean, look what John did with Blue Cross Blue Shield. He's not waiting for pay-for-performance. He's going right to payers. So so we'll see. We'd like to see Medicare stop pay-for-reporting and start paying for performance, because I'm telling you what, we're not going to make any difference in reimbursements if we don't change from pay-for-reporting. PQRI is pay-for-reporting. Did you document the T's and the R's and the I's? Did you tell how many patients fell? Did you record that? But what were your outcomes for that assessment? And that's pay-for-performance. And that's, as physical therapists, we need to educate regulators that it's not sufficient to be paid for reporting. We have to pay for performance. And then we can make a difference and see the differences between clinics and really get a meaningful comparison with clinics. So that's the... I don't know what time it is, Judy. I'm kind of talking. Okay. This next part, again, that's from a evidence-based perspective. Did anybody have any questions? It's too late in the afternoon. Lunch is down. Again, using data to make decisions is very useful if you want to take the next step to evidence-based practice. That's how you should use the information. Not why, but how do I use it? And this is an example of how I would use data, practicing evidence-based practice. Understanding the literature, interpreting that from my clinical experience, and making sure the patient is part of the plan, because their goals are very important. Understanding their assessment is very important. My clinical assessment is important, but so is theirs. And they both have to be integrated together to get an idea of what's going on. And again, you can think on your feet here. If the patient is telling you, I can't climb a flight of stairs, and yet you find no impairment criteria to support that, then why not have patient climb stairs as their treatment? Or develop an exercise program that supports climbing stairs. I never give a patient an exercise unless that exercise is linked to a function. And I say the only reason you're exercising is so you can maintain your function. So what? Today is nothing. You're 70 years old. What are you going to be doing when you're 75? This is a plan that you need to follow to maintain your function. So again, functional orientation for your patients is important. Using exercise to push function is very important. And again, that's how I try to do it. If there's a miss between self-report and the clinical performance, so I try to make them match a little bit easier during the treatment episode. And that could be chronic or acute. I don't see that as much as a big deal, but chronic I do, and geriatrics I do. Okay, so that's the professional viewpoint. The other viewpoint I thought was handled pretty well by John this morning is a practical, what's in it for me type of perspective. I could just add in a couple other analogies. I work in a hospital system, so Press-Ganey is the gold standard. Does anybody else have to deal with the Press-Ganey? They live and die by the Press-Ganey. What's your ranking, by the way, for outpatients in the last 2 months? I bet you everybody knows because they always tell us. I mean, we're at 92 percentile or you're 95 percentile. It's all based on satisfaction. That's the happy customer model. Keep them happy. Don't worry about quality. All right. Why is that a problem? Well, let's say you're an entrepreneur like John is, and this is his geographical area, which was Durham. And he sets up practice in this geographical area. He's a dedicated clinician, really motivated. He only hires dedicated clinicians, and they build a thriving practice. Well, they certainly know the importance of word of mouth, and they certainly understand referral sources and how to market those referral sources, and they're successful. 4 years later, well, chiropractic, rehabilitation, wellness, fitness, acupuncture, massage clinic opens up down the street. And then a corporate giant comes in and puts in a satellite clinic. Says, go get them. So now you're all thriving within the same geographical area, and now you become competitors. Well, the economy changes. A regulator comes in and a payer comes in and says, ooh, well, you know, you're all in business. And because you're all in business, you're all delivering the highest quality of care. So I'm just going to cut you down 10% across the board because, you know, I can't tell the difference between you. So, too bad. Well, Clinic A steps up and says, that's not acceptable. I know the mill that they're running down there. We don't see 7 or 8 patients an hour and have other people treating patients as they sit and have coffee. We are dedicated to our patients. We make a difference. Prove it. Well, they did. They changed the perspective in which that they were going to market. Happy customer model didn't work, so they had to turn on a quality of care model, which is basically what photo is. It's a quality of care model. And they could demonstrate that not all clinics are the same, and they do not deliver the same quality of care. Reimbursement should be paid. In a capitalistic society, reimbursement is paid according to the product. You have higher quality product, you have a BMW, you pay more than a Ford. Right? That's the way it is, and that's what Clinic A went with. How did they do that? They collected data. And as John said this morning, in God we trust, everyone else bring data. Data is a very powerful tool to educate, and educate. And I think payers have listened. Certainly dentists over the past 2 days and JW have been very successful with data. You're not going to come in and say, I'm the best. You know, the 2 competitors that John was talking about, this was a very well-established hospital in his area who advertised the best orthopedic surgeons. And of course, they've educated and trained the best orthopedic physical therapists. Based on our reputation, we deserve higher reimbursement. Well, not so fast. Okay? So it's not just happy customer model. And I said, and then Blue Cross said, well, where's your data? Well, and actually the week later they called Judy and started trying to collect data. But the idea here is you need to be link. See, insurance companies want to be efficient. Let's just, like Michigan, let's chop them off at 6 visits. Come on. Well, you know, that may work for the insurance company, but it's not quality of care. Why? What hasn't happened? The effectiveness has not been linked to efficiency. Both are critical. And that was what the pay-for-performance model proposed by Dennis was. You have to combine both to make a rational assessment of the quality of care you rendered. And if you do that, you should drive reimbursement. So you need effectiveness and efficiency, and of course, overall performance can only be judged through risk adjustment. And Dennis went over that for a good hour this morning. If you're not risk adjusting, then don't talk to me. And we have to educate payers why that's so important. Boy, it's critical. We went over that example. Athletes, geriatric. You want your money cut because you have to see geriatric patients? That's not fair. You do a better job based on risk adjustment than they do. So educate those payers that risk adjustment is critical. You're on a tool, the most sophisticated risk adjustment tool out there. And you should appreciate that tool and use it to your fullest. I think. Well, I think that's pretty exciting because, like I said, the answer already was yes, why you should collect outcomes. You can take a professional perspective in road, or you can take a practical perspective in road to grow your business, but they're all both going to come here, and you're talking to the same endpoint. So again, the quality of care model seems to be very effective. I'm not going to go into this any further. John talked about this morning. We did develop a research group or a marketing group from 5 clinicians with similar interests. These were credentialed and diplomat-trained physical MDT therapists. Our primary purpose was we were fed up, we wanted to stand up and implement a quality of care model. We didn't know if we were going to be successful or not. We were going to let the data flow. Good thing that the data flowed our way. But even if it didn't, we could still collect outcomes and educate that this is an important way to progress. And we had to standardize data collection. Standardize, standardize, standardize. So optional patient surveys. I think I have at least, well, I have the global rating of change in there. I think that's very important. We have the SEL 90R somatization depression. We have fear of work when it's applicable. We have the pain module. But we've modified the pain module because there's too much information in the McGill. I don't need all that information to understand my patients. I guess if you were in a chronic pain clinic, you want the whole McGill. But we've turned on components of what's important to us. Obviously, pain intensity is very important. In Medicare, too. So we've, again, customized the intake process and been very successful at it. How long does it take patients to fill all this stuff out? 10 minutes, 15 minutes, certain cases never longer than that. We've been doing this data for 6 years. And if we actually have a limit, if the patient is still answering the sex question after 20 minutes, okay, that's it. We're not going any further. Well, we don't have to wait 20 minutes, but you get the idea. So that patient is now flagged in the non-participation audit, which you can go into maintenance and turn that on. Why is this patient not participating in photo? You know, that may very be helpful when your management is interested in your participation rate. Well, it's just as valid to report why they're not going on to photo. You know, you got to tell them, hey, I just had 15 Russian patients. So, you know, you can document why you're not getting them on photo. And then you should try to document why you can't get a follow-up. Some people just leave. Some people have medical emergencies. Some people can't handle the schedule because they have to work and babysit and do everything else. Well, this is good information to document, to start looking at why you're not having the participation and completion rates that are expected, so to speak. So you collect data to understand that problem. And again, so as we standardize, and the other important part, and Tamara, yeah, mentioned this, we really want to document, besides our examination tests, I went all over that, we want classification, we want to document treatment processes. What treatments seem to be attached to the best outcomes? And again, Daniel Deutscher is taking the lead in that, and we hope our data can be included in these analyses to find out what is cognitive behavioral, as we've defined it, an important treatment component attached to this risk-adjusted model to drive this particular subgroup of patients to an improved functional outcome. What are the ingredients to get us there? So all this stuff seems to be exciting, and hopefully we can share more information as we continue to learn. I almost sound like a statistician. You need more data to learn. If you're going to improve your risk adjustment, you need more data. And the same thing as a clinician. If we are going to travel the road of first contact clinicians in a direct access environment, you need more data. You can't stand there and do range of motion, manual muscle testing, is he shifted, is he not shifted, and then make all your patients have good outcomes. You may have to have multiple constructs and change your treatment strategies from visit to visit as that patient changes in front of you. And that's what you want to observe. Either for the worse or the better, you have to be able to take data and make changes on your feet. And again, John went over this very briefly. This is risk-adjusted comparisons. The point I wanted to get to is we were able to demonstrate overall performance with the quality of care model. What happens when we turn on the happy customer model again? We're not any different. We're all the same. We all do a good job in happy customers and happy patients, otherwise you wouldn't be in business. Is that enough in today's environment? I don't think so. If you don't think it's competitive, just go to a chiropractic policy meeting or something like this and see what's going on. We're in high competition. And insurance companies are going to tell us what we're going to do, or we're going to tell them what we need to do to start comparing each other effectively. And photo is independent of provider type. You know what that means. We can compare outcomes between physical therapists, doctors if they're using it, and chiropractic, or anybody else who's using it. It's independent of provider type. That's pretty good. We just got to get everybody to start using it. And then we can make more valid judgments. But maybe the payer is the one who's going to force that issue, if we can educate them on the value of this. But let's get rid of this happy customer model. You're no different. You're no different than anybody if you want to keep that up. You better start demonstrating quality of care model and using that. John went over that this morning. Again, I told you the answer in the beginning. Yes, we need to collect outcomes. I think it's important professionally, and I think it's important practically. You want to stay in business? Better start doing it. Again, John mentioned some scary statistics in the UK. Is the US following the UK? Hopefully not. We'll see. Why? What's happening? We live in a world of shrinking reimbursement. You don't think that's true? Well, you bet sure it's true. Increasingly difficult healthcare environment? You bet. And you think the scientific community is not being scrutinizing? They certainly are. That's why UK is losing some leverage on physical therapy, because they have all these experts in clinical practice guidelines telling them what they what they can and cannot do. Well, we need more data to demonstrate that's not true. So again, hopefully this was of interest, and any further questions, we'll be here tomorrow too. So.